হ্যাঁ আমি আসছি
মিউট আসেন কবির স্যার না আসলে
হ্যালো আসসালামু আলাইকুম
শরীফ ভাই শরীফ ভাই জয়েন করেছেন
আসসালামু আলাইকুম
আমরা ওয়েট করতেছি
আসসালামু আলাইকুম স্যার
দেখা যাচ্ছে
স্যার দেখা যাচ্ছে স্যার
স্যার আসসালামু আলাইকুম
ওয়ালাইকুম সালাম
ভালো আছেন স্যার লতিফ স্যার
কবির ভাই ভালো আছেন তো না
ভালো আলহামদুলিল্লাহ
আমি আপনাকে এসএমএস করছি
রাগও কেন?
কোনো রেসপন্স পাইনি এর জন্য ছিলাম
খাচ্ছে তো
ও না আমি খেয়াল করি নাই বোধহয়
দাও ওইটা থেকে দাও এভাবে বুঝে দাও খাই না
স্যার আমি আসিফ স্যার আমি আসিফ বলতেছি স্যার আসসালামু আলাইকুম ভালো আছেন স্যার
আসিফ ওয়ালাইকুম সালাম কেমন আছো
আছি আলহামদুলিল্লাহ স্যার স্যার আপনি ভালো আছেন
ভালো আছো না
স্যার
আনিস স্যার
স্যার আসসালামু আলাইকুম এই ব্রিগেডিয়ার লতিফ স্যার ভালো আছেন স্যার
গত দিনের মতো
আলহামদুলিল্লাহ
হ্যাঁ আপনি আমাকে যখন স্পিকার কথা বলবে তখন সবাইকে আনমিউট করবেন বুঝছেন
আসসালামু আলাইকুম স্যার
ওয়ালাইকুম সালাম
আসসালামু আলাইকুম সিরাজ ভাই
জি আসসালামু আলাইকুম
শুভেচ্ছা বিনিময় তো শেষ হল না
জি আমি ডাক্তার আসিফ ভাই আসসালামু আলাইকুম
ঠিক আছে হ্যাঁ এই তো হ্যাঁ জয়েন করেন দেখা হচ্ছে এভাবে দেখা হয় দেখা যাচ্ছে
আমাদের এই মুহূর্তে 68 71
ঠিক আছে
71 আরেকটু ওয়েট করবেন নাকি না শুরু করবেন
বাবা কটা বাজে
হ্যাঁ
আমাদের স্পিকার যদি অফ না থাকে
আমাদের প্যানেল অফ এক্সপার্ট সবাই চলে আসছেন সবাইকে
সবাই
ধন্যবাদ লাইন জয়েন করার জন্য
হ্যাঁ রাশেদ
হ্যাঁ আসসালামু
আসসালামু আলাইকুম রাশেদ ডাক্তার আশরাফ
কে ডক্টর ও আরে কি খবর কেমন আছেন আসুন ভাই ভালো আছেন
74 participants
স্যার আসসালামু আলাইকুম মধুসূদন দাস বলছিলাম ইউনিডার্মা থেকে ভালো আছেন সবাই স্যার
জি জি
ভালো
ছবি চৌধুরী স্যার চলে আসছে
বাকিটা হ্যাঁ
আইনা আছে দেখছি নাহিদ পারভেজ নাহিদ কোথায় তাজিন নাহিদ পারভেজ
রাশেদ ভালো
জি সালাম ভালো আছে আপনি আরো স্টাক কানাডায় নাকি কবে মানে আসবেন দিকে নাকি
এই যে বুকিং দিছি এখনো কনফার্ম করে নাই
বলেন আপনি
আচ্ছা ডিফিকাল্ট বাট 3 গুণ দামে বুকিং টিকেটের দাম হচ্ছে 3 গুণ এরকম সামথিং লাইক দ্যাট নাকি
না দাম বাড়ায় নাই
আচ্ছা
প্রথম বাড়াইছিল এখন কমাচ্ছে এর লক্ষ্য চাইছিল এখন বলছে 87 কমাচ্ছে প্যাসেঞ্জার হচ্ছে
আসসালামু আলাইকুম
ওয়ালাইকুম আসসালাম
ফোনে পাই না আপনারে ফোনে পাই না
পাবেন
এই বকটা এই বকটা কে দেখেন
কবির ভাই
হ্যাঁ বল
আমরা কি শুরু করব না ওয়েট করব
আমরা শুরু করে দিই মনে হয় লেটস স্টার্ট
হ্যাঁ অনেকক্ষণ 10 মিনিট বেশি হয়ে গেল না 10 মিনিট
হ্যাঁ 83 participants already joined
গুড এরকমই হয় अराउंड 100 হয়
তাহলে কবির ভাই শুরু করি
না এটা
বিসমিল্লাহ
ওকে
স্যার শুরু করার আগে আমি সবাইকে একটু মিউট করে দিচ্ছি স্যার মিউট করে দাও আমাদের কথা
Dermatologist of Bangladesh, I like to welcome you all to join today's webinar on common uses of laser in dermatology practices. This webinar has been arranged by Association of Cosmetic Dermatologists of Bangladesh. It has been sponsored by Uniderma Limited Bangladesh. Today, we have selected such a very important topics, that is uses of lasers in dermatology and aesthetic dermatology. I think many of us have been using dermatological lasers in our daily practices. And also many of our junior dermatologists has already started using, or most of them are very much interested to start practicing lasers in their dermatology practices. So I think our selection of topics is very important at this moment, because at this COVID-19 pandemic, we are almost free. Many of us even not attending our private chamber. Some of us may be just attending a very limited scale of practicing, that is only in telemedicine. And maybe few of us have already started practicing our dermatology in our private chamber. So mostly we have enough time at this moment in our hand, but still we are enjoying ourselves with our family, friends, and also with these webinar meetings in different topics. And already we have arranged a number of topics, webinar meetings by our Association of Cosmetic Dermatologists of Bangladesh. And today we have selected common uses of laser in dermatological practice. Today we have invited as a keynote speaker on this topic, Professor Dr. Swapnil Saha, who is a very renowned and very high skilled and expert in the field of laser in dermatological practices. Whenever I go to attend any laser or aesthetic dermatology conference in India, I have observed, I have seen that Dr. Swapnil Shah always come forward to present topics of lasers very nicely. Every time I have seen, he is one of the most legendary in the field of laser practice in dermatology. That is why I have invited him to join in this webinar meeting. I just give heartfelt thanks to him to join with us in this today's webinar meeting. So first of all, I would like to seek permission from our chairperson, Professor Dr. M.U. Kobir Choudhury, who is the president of Association of Cosmetic Dermatologists of Bangladesh. I just seek permission from today's chairperson, Professor M.U. Kobir Choudhury, to start today's webinar meeting.
Okay,
Sir.
welcome. Please, you can proceed with your program. Yeah,
Thank
the
you.
wonderful topic is common uses of laser in dermatology. Very, very burning subject. Yes. Welcome.
Yeah. Okay.
Welcome all to this program, including the keynote speaker and all the learned dermatologists.
Thank you, sir. I'm going to start today's webinar meeting. I welcome you all. We have divided this webinar meeting in a number of parts. First, I will invite our Secretary General of Association of Cosmetic Dermatologists of Bangladesh, Professor Dr. Rashid Mohammed Khan, to give welcome address to this webinar meeting. Then I will invite today's speaker to deliver his presentation. Thereafter, there will be question-answer session. And then we have our panel of experts. They will give their expert remarks and comments. And thereafter, there will be vote of thanks that will be given on behalf of Uniderma Limited. And then our chairperson will give his chairperson's speech and closing remarks. So I think, and I hope that we all will enjoy this session, because we have started, or we are going to start, or we have interest to practice laser in our daily practice. So it is a very short journey in the field of laser in Bangladesh. Maybe we have started either last of the 19th century or initial years of 2020. You'll be surprised that I have done my fellowship in laser and dermatologic surgery in 1996. But till 2006, for last 10 years, I could not start practicing laser because the laser machine was very costly at that period. Thereafter, in 2006, I have done another fellowship in dermatologic surgery and laser in Ramatibori Laser Center in Bangkok. Then I have started my journey of laser. First, I have purchased only CO2 laser. Thereafter, I purchased one Q switch laser and then IPL. But by this time, all of you know that many of our colleagues and our fellow dermatologists have started practicing lasers in their practice. And by this time, all of you know that maybe so far I remember Professor M.U. Kobir Choudhury, he was the pioneer to start practicing laser in Bangladesh. Then I have seen Laser Medical Center, Dr. Jumu Khan's Laser Center. They have been practicing laser for last many years. Thereafter, Dr. Sharka Shamim, he has started his laser treat. And by this time, many of other colleagues, other dermatologists has started their laser practice in their dermatology practice. So I hope that everybody of us will be benefited hearing from today's speaker, Professor Dr. Swapnil Shah. So I will invite all of you to enjoy the session. Now I am going to invite Professor Dr. Rashid Mohammed Khan to give welcome speech on behalf of Association of Cosmetic Dermatologists of Bangladesh. Professor Dr. Rashid Mohammed Khan.
Thank you, Professor Shiraj. We always say that man behind the machine is very important, especially if the machine is a laser. There's so many types of laser. By this time, from nanosecond to picosecond lasers, there are so many types of laser that come. And to treat a condition, we need combination of lasers. Which laser is applicable? What type of laser will be applicable? What type of skin we are going to use on laser? There's a lot of experience. So man behind the machine is important. So we want to become important man behind the machine. And for this reason, I would like to welcome Professor Dr. Swapnil Shah, Professor of Dermatology, Australian Medical College, and also the Vice President of ACSI, that is Academy of Surgeons of India, Cosmetic Surgeons of India. He'll be here to discuss about different types of lasers. I believe for all of us, it will be a learning experience. I also especially welcome our President, Professor M.U. Kobir Choudhury, and our distinguished panelists will be discussing their experience on lasers. And special thanks to our participants who have joined this webinar, who are interested in laser practice. I welcome everybody. So I believe I'll again welcome Professor Dr. Swapnil Shah for his keynote speech. Thank you very much.
Thank you, Professor Dr. Rashid, for your nice welcome speech. Now I am going to invite our today's keynote speaker, Professor Dr. Swapnil Shah from India. He is a very learned, very expert fellow in the field of practicing lasers in dermatology. So far I have observed he is one of the best laser specialists in India and throughout this subcontinent. He is the Professor of Dermatology in Oshini Rural Medical College, Solapur, India. He is the Vice President of Association of Cutaneous Surgeons of India. And also he is holding positions of many different organizations in the field of dermatology, aesthetic dermatology, and laser dermatology. Now, it is my pleasure to invite Professor Dr. Swapnil Shah to speak on common uses of laser in dermatology and aesthetic dermatology practices. Dr. Swapnil Shah, please.
Good evening, everyone. It's indeed an honor and pleasure to, talk in front of this esteemed panel. Uh, Lasers is my core interest, and I'm very, very thankful for the Association of Cosmetic Dermatologists of Bangladesh for giving me an opportunity to present my work. We know that lasers is being used in our practices since long time. There's no conflict of interest. As I said, I am very much thankful to the Association of Cosmetic Dermatologists of Bangladesh, especially Dr. Sirajuddin sir and Dr. Kabir Chaudhary sir for inviting me and giving me a chance to present my work. However, I must disclaimer that the topic is very vast because I'm going to talk on plenty of lasers. And even if you feel that you want to stop me somewhere, you can easily stop me and ask questions, or you can ask me to stop completely because if I overshoot the time. With this, I came from Solapur. This is a very small town in Maharashtra, which is near to 300 kilometers from Mumbai. That's to clear my position. So I'm from semi-urban India, not from the 4 metros which you commonly know of. So this is my place where I practice. I'm attached to a medical college and I'm in a private practice since last 15. So coming to the topic, today's is lasers in dermatology, and we know that laser is a device for creation, amplification, and transmission of intense beam of coherent light. And this summarizes what is laser. Basically, it's a light amplification by stimulated emission of coherent radiation. Laser provides remarkably specific, precise, and effective form of treatment for many of the diseases where there was no therapy which was existed previously. So basically laser is a magic wand, and whom use the magic wand is also important. The man behind the machine, as Dr. said, is very important. If it's been used by a potter, it's be light amplification by stimulated emission of radiations. But if it is used by this guy, then it is a loot acquisition by skimming for expensive research. So we have to choose your laser and use your laser very carefully in our day-to-day practice. Laser has definitely changed dermatologic practices. From Dr. No, that many of the almost 30% of our practice, we used to say that there is no treatment available. From Dr. No to Dr. Never Say Never Again, we now almost treat everything in our practice. Coming to the historic aspect, the genesis of laser goes, and the credit goes to this guy, Einstein, who postulated the quantum theory. And from 1972 to the 1960, the first ruby laser was introduced by Maman, and Goldman is supposed to be the father of dermatological laser. He used first argon laser for treatment of port wine stain. And I'm proud to say that 1964, Patel, which is Dr. Patel, he's from Pune, which is around 200 kilometers from my place, invented the CO2 laser in US, and it's been still very commonly used in our day-to-day dermatology practice. So what makes laser special? Why it is special than other forms of light? The difference between a laser and a conventional light source is we all know that it is monochromatic or made up of one wavelength as against light, which is of plenty of wavelengths. It is collimated, that it travels in one direction, and it is coherent, that in phase. So the basic difference of these three makes a laser very specific in our practices. It is monochromatic, it is collimated, and it is coherent. The wavelength of the laser is determined by the active medium of each particular laser. Active medium can consist of a gas, as in CO2 laser or an excimer laser, or a liquid, which is been used in pulse dye laser. A solid laser, which has been commonly used in our practices, are Alexandrite or Nd:Arg laser, or there are long pulse or a Q switch laser, and a semiconductor lasers such as diode lasers, which has been rapidly becoming popular in practice. So when a light falls on our skin, what exactly happened? The light has light can interact with the incident target in one of the three different ways. Either it is transmitted, or it is reflected back, or it is absorbed. And the only absorbed light has a clinical effect. That's very important. The light has to be absorbed by something which then only will get a clinical effect. This paper in 1981 by Anderson and Parish, we all listened to this plenty of time. This had changed the use of laser in our settings. The idea involved is hitting our target tissue without overheating the surrounding tissue by restricting the time in which laser energy was applied, thereby minimizing collateral damage and scarring. So the selective photothermolysis is discriminant. Photo is light, thermo is heat, and lysis is damage. Selective photothermolysis, for selective photothermolysis to happen, we required chromophore. As I said, for the light absorbed only will show some effect. Transmitted and reflected light is a waste. So what are the chromophores in our skin? Water, melanin, or other exogenous pigments like tattoo pigment, hemoglobin, collagen, etc. acts as a chromophore for the wavelength to be get absorbed. The wavelength is selectively absorbed by this wavelength, and there is a famous chart which I'm not going to show, but all of the laser users know that chart. What is more important than simply having a wavelength is a current pulse duration. The laser has to be pulsed than a continuous wave, because pulse laser has a peak energy and they restrict the damage to the only to the chromophore. The fluence has to be used. The correct amount of energy needs to be delivered for the destroy or to change the target. The spot size has to be corrected. You have to have a large spot size, because larger spot size allows us to penetrate deep by decreasing the refraction caused or scattering caused of the caused by the collagen. And it has to be the laser has to be cool enough to prevent the damage to the surrounding non-targeted tissues such as epidermis. So these are basic principles of selective photothermolysis. I will not waste much of time on basics because I believe all of them are expert users. The main indication for laser therapy in dermatology are for hair reductions, where melanin and the vasculature at the bulb area is primary target, and we have to selectively destroy the stem cells at the hair shaft so that no new hair should come out of it by targeting the melanin and the bulb area vasculature, the capillaries in the papillary dermis. For pigmentation, melasmas and tattoo, melanin or external pigment is our target, and we have to selectively destroy it depending on whether it is epidermis or dermis or both. Vascular lesion, I'm not going to touch on it basically because I have a very limited experience. I started I started using vascular lasers since last 6 to 8 months. I will not waste much of my time on vascular lasers. Water tumor, scars and wrinkle, the chromophore is water. We can target it with either CO2, erbium YAG or microneedling RF. An excimer laser, which is a cornerstone of dermatologic treatment. These are all aesthetic lasers, but excimer is a dermatologist laser, and they target nucleic acids either in the lymphocyte or in the skin. Coming to the laser hair reduction or removal, which is been marketed as removal, has now been changed as laser hair reduction, and now it is called as laser hair long-term reduction of hairs. It is not even permanent. So it is still been widely used for the permanent reduction of hairs. One of the most popular laser procedures performed, and almost everybody knows about it. So most lasers for these hair removal targets the melanin within the follicle, thereby transmitting heat to the stem cells in the bulge area and dermal capillaries, and hitting them and destroying that target. So what are the lasers which is being used? Alexandrite is the cornerstone in white skin from type 1 to type 4 skin. But in subcontinent, what I feel is 810 and more so 1064 is the safest laser to be used, simply because 1064 has a less affinity to melanin than 810 than 755. So since it has a less affinity to the melanin, epidermal melanin is going to get less, it is going to be less absorbed by the epidermal melanin, and also it can penetrate deeper. IPL is basically not a laser, but it uses multiple wavelength, and we all know about it. Recently, there are few lasers which are available with dual wavelength lasers and triple wavelength lasers. Like these triple wavelength lasers, I'll be talking a brief about it in coming slides. So, is it possible? I don't think so it's possible. So what we need to do, we should look for the signs of hirsutism if a female present with laser hair removal, and if we find that there is a signs of hirsutism in the lady, we should get a complete hormonal checkup. generally, in my experience, it took 10 to 12 sessions for good control of hair removal, and that's why we should counsel the patient in a similar way. We should promise around 60 to 80% reduction in the hair, and we should also warn them about requirement of the future sessions, like they may require a touch-up or maintenance session in future, even after 10 to 12 sessions. As expected, white, gray, and thin hairs are generally respond poorly, and we should choose our patients very selectively. Long pulse, as I told you, and diode has allowed safer treatment with fewer complication, and cooling adds to safety of LHR. So even if your machine has an inbuilt coolant, it is a cooling system like a contact sapphire tip cooling or a cryogen based cooling, it is always recommended or it is always better to have an external cooling devices such as Zimmer for allowing increased safety and tolerability of the procedure. What's new? There are a lot of new lasers which has come up in the market with a large spot size. Some have 20 by 20, some are 20 mm in long pulse Nd:YAG, or even better. Then there are linear scanning diode which actually split the, it is something very similar to the scanner mode of long pulse Nd:YAG, which scans the entire area with a very small spot size, but that increasingly becoming safer and painless, and especially very good for whole body hair removal. Then large spot with a vacuum to decrease the pain and to increase the safety. We all know about super hair removal or in motion laser hair removal, and there are now triple wavelength laser available, which has been where they are actually using a diode to produce 755, 810, and 1064 nanometer wavelength, and they are predominantly being used in SHR. Standalone use of these laser for isolated use is difficult because the pulse width in these triple wavelength laser is not defined. And recently, Luminous has come with a dual wavelength solid state laser with a long pulse Nd:YAG and alexandrite separately, which you can follow one after another independent of each other, or you can combine these two wavelengths and offer, and that becomes an exciting option for hair removal because you can virtually treat from very fine hairs to very thick hairs, and from type 1 skin to type 6 skins, all inclusive. So in nutshell, nothing has been changed since its introduction of laser hair removal since maybe 1990s. The LHR has become more fast, it is more safe and more painless. So all these technology, the newer technology makes it faster, safer and painless. It does not alter the basic physics. And few of my patients, typical hirsute where she's been referred to an endocrinologist, and at the end of 7 to 8 session, this is 3 months or 4 months post treat, fourth, 7th session, and she still had some hairs over here, and we expect she required another 3 to 4 sessions for this. Again, typical hirsutism with the chin, excess hirsutism on the chin and lips, and as expected, the chin has responded well, but if you see the hairs are on the lip are still coming back, and you required more sessions for them. Another session, nine sessions with hirsutism and responded well. This is from my friend. Yeah, apart from hirsute, we get a lot of mails for air pinna. Here we do typically once in 2 months or once in 3 months, once in session, but they do respond nicely in 6 to 7 session. This is of courtesy my friend, and this is after body hair after 10 session in a case of male. This is, I call it as a long-term hair reduction, and it is not a hair removal permanently, because this patient is going to get his hair, some hairs back, and we need to treat him for more time. So here is the similar story. You can decrease the density, you can make them thinner, but you can't completely remove them in most of the cases. Apart from aesthetic indication, we can use it for medical indications like Fontaine, nevus, which is very common after, and it's a treatment of choice. You get good results in around 6 to 7 sessions in these patients. They can be treated at any age. Another case of Fontaine level after 7 session with a good control of her hair. This is an interesting case from Dr. Sakya. This is a case of recurrent pilonodal sinus, and if you can see, he's been operated twice or thrice with a recurrence. So what he did is he used his diode to treat the entire area for hair removal, and we know that pilonodal sinus, the cause is ingrowing hair, and after that he hardly has any recurrence, and that's where you can use your diode for hair reduction in pilonodal sinus. I've been using it for hidradenitis suppurativa successfully, along with combination of medical treatment and MNRF. And we find that reducing these hairs definitely prevents or prolongs the remissions achieved by medical therapy. So you can use it in hidradenitis suppurativa. Again, it is from Dr. Sakyan. It's a very interesting case. This is a mucosal flap post CA. And if you can see, the hair are started growing it inside the mouth, and he used diode in a free flowing manner, I mean non-contact method, and just eradicated. Because there is no competing chromophore here, he can safely use an aggressive fluence, and after 5 to 6 sessions, you can get a good growth, hair growth removal from these places. And this is what I showed. What is it possible? If you remember the first slide which show whether this is probable, this is from my friend. He is Dr. Amit Shah, and he got this patient with hypertrichosis lanuginosa congenita, and he treated with long pulse NDIAC for around 6 to 8 sessions. Obviously, these are lanigo hairs, less pigmented, so we don't expect them to get completely removed. But this is a life-changing procedure for this guy, this poor guy, and he improved a lot. And this has been covered on Discovery Channel, and he is on that. You can see that. After laser hair removal, my treatment of choice and my favorite laser is a Q-switch laser. Laser for pigmented lesions and tattoos. We know all in subcontinent, we are all obsessed with fair skin. And I mean, you definitely can't make a person fair with a Q-switch laser, but you can make him uniform in skin. The color and texture become uniform.
Dr. Swapnil?
Sorry?
Just for 1 second, please.
Yes.
Dear participants, if you have any questions, then please write down on the chat box. Thereafter, when a question answer session will come, I will just bring this question to speaker. Please, Dr. Swapnil.
Yeah. So we all know that pigmented lesions result from excessive or abnormally deposited melanin or other pigment in epidermis, dermis, or both. Melanin is present in skin stored in melanosome in keratinocyte and in melanophages in dermis. Melanin has a broad spectrum of absorption. So from UV rays to infrared rays, everything is going to be get absorbed by melanin. So every single laser which we are going to use is going to have some effect on the epidermal or dermal melanin. Longer wavelengths are generally preferred in treatment such as 1064, since as I explained, they have a less affinity for melanin and they do penetrate deeper, and that's very important in treating dermal lesion. The mechanism of action is photoacoustic plus photothermal. The laser energy is absorbed by the pigment, which generates the shock wave in the cytoplasm. The cytoplasm is rapidly evaporated, which creates a vacuole inside the cell. There is a sudden vibration as the shock wave collapses. There is a vibrational damage to the cellular structure and the rupture of the cell membrane, which results in destruction of the cell. And because of there is sudden vacuolar formation, what we see in Q-switched NDIAG is the frosting, which is seen on the skin, is because of this sudden change in light scattering properties of skin. The indication for Q-switch NDIAGs are innumerable. You can treat epidermal lesions such as freckles or simple lentigo. The lesions in red you can treat, but the laser is not a treatment of choice, especially for the Becker nevus and calm. Generally, the results are not great, and I don't use much of the Q-switch laser in Becker's neocellular nevi and pigmented seborrheic keratosis. This forms the treatment of choice. Nevus of Ito, abnorms that acquired bilateral nevus of Ota-like macules, drug-induced hyperpigmentation, LPP, tattoos, they are very well can be treated with Q-switched or by now Pico laser. Coming to the epidermal pigment, 532 has a high affinity for melanin. That should be a treatment of choice in a white skin or in a type 3 or type 4 skin. But beginner or in dark skin, one should always use 1064. There are few wavelengths with the few machines. The 670 nanometer like ruby-like wavelength is also available, which is slightly safer than 532. The spot size has to be correct. I mean, you have to select the spot size according to the lesion if you are using 532. Less frequency, no overlap, and hand feet should always be held perpendicular. The endpoint of 532 is very important. You should not look for the uniform white frost, which has been described. In our skin, we should look for the white eccentric frost, white eccentric minimal frost. If you achieve this, this is going to heal with either hypo or hyperpigmentation. A white eccentric pseudo white frost will not land you in trouble. And minimum fluence that induces this faint eccentric voice frosting should always be used. And this is a case of freckle. which has been treated with one single session of 4 mm spot size, which is actually 3.2 mm with 0.7 joule per centimeter square. And in a single session, you can get just in 8 days. If you see, just in 8 days, you can get almost complete clearance of the freckles. So 532 in a whitish or a white skin, I mean fair skin, is still can be used. This is again a freckle. We are used it again with 532, and in 2 or 3 sessions we can get able to it. But if you have a type 5 or type 4 skin, it is best to use 1064. I used 4 mm 9 joules once in a month for 3 months. So 532 will give you results in 1 month, but 1064 will require 2 to 3 months. And even with that, you can safely treat all these lesions successfully and safely. So obviously we are all aesthetic dermatologists also, and we want safety to be primary cornerstone of our treatment. So you can still use 1064. You can use it for solar lentigo like this, 1064, 4 mm 9 joules once in 15 days and 2 sessions with a almost complete removal of the solar lentigo. Coming to the dermal lesions, apart from the epidermal lesion, Q-switch lasers are the cornerstones in dermal lesion. 1064 is the safest wavelength. You can play with it as you want. The results are always rewarding. You should start your treatment with a spot as large as possible, and fluence that uses uniform white frost. Here it should be uniform white frost should be used. Generally, these procedures are done under topical anesthesia. In subsequent session, you can increase the fluence to observe the similar frosting. After few sessions, the spot size needs to be reduced, and start treatment as soon as possible. If the patient of nevus of Ota comes to you, you can start treatment in his childhood. The youngest person I have treated, youngest kid I have treated is around 3.5-year old. Because it's been proven, there are good number of papers which shows that less number of sessions are required, and there are less complications because you require less fluence to achieve this. And in adult, you can always combine it with fractional CO2 in same session to achieve faster clearance of lesion. Now, this is my first case which has been treated with 1064. So I used 1064 4 mm 8 joule 6 session once in 6 months, and the nevus of Ota is reduced. I mean, it's improved, but if you can see, there is a lot of pH. And why there is a pH? Because I used a small spot size and a very high fluence, and I placed my treatment every month. This patient has taught me something. She presented with me a nevus of Ota. She is dark skin, so I used around 3 joules and 7 mm spot size, and she reported me after one session 6 months back, and second session again 6 months back. So in a year, I was able to do only 2 sessions, and to my surprise, her nevus of Ota almost got cleared just in 2 sessions. So when I search the literature, now we do treatment once in 3 months and not once a month. The more you place the treatment, the lesser number of sessions will be required for this. Another patient of nevus of Ota with a good clearance. These pickled nevus of Otas are difficult to treat, but we treated her with some PIH. But more worrying than PIH is this confetti leukoderma, which has been there by using a small spot size. So we stopped using a small spot size for nevus of Ota now. So just in 2 sessions, you get a good clearance of nevus of Ota once in 3 months. And this is 4 sessions once in 3 months. Sorry, this is not 4, this is 5 sessions once in 3 months. And now with 6 mm or 7 mm and 3 to 4 joules, we will able to almost completely clear the nevus of Ota without any epidermal damage or color change. And this is the 3.5-year-old girl. We started treating her with once in 6 month session under just oral sedative like a triclophos suspension and a topical anesthesia, and on the mother's lap, and just in 3 sessions or 4 sessions 6 months apart, what we could achieve is remarkable. So by the age of 6 years, that's a preschool age, the child is completely cleared of her nevus and blemishes. She can be confident while going to the school. Epidermal nevus, you can treat it with 1064, still with 1064, and you get a good lesion in 6 lesion. And this is nevus pilus, like I was talking about CAM. And here we started using a combination of 1064 and 532 in one single session. So what we do is we treat it first with 1064, followed by 532 immediately when the frosting goes down. So we do 1064, wait for 5 to 10 minutes till the time frosting goes off, and again it treat with 532 with the lower parameters. And these teams are working in in CAMS and nevus piluses very well, and we have submitted our paper for this. FD is a cakewalk. I mean, you can treat it with simple 1064 and large spot size without any problem. Lichen planus pigmentosus, again, a very difficult condition to treat. Plenty of names are there, lichen planus pigmentosus or erythema duxchromium perstans or pigmented photocontact dermatitis. It's very difficult to pinpoint at one clue. Various treatment options are there, but the treatments are resistant. I mean, the pigment is resistant. Even you can stop the progress of the disease. Generally, it takes a very long to clear the complete pigment. So we used a medical line to stabilize the disease. Especially, I used a low dose isotretinoin with topical tacrolimus to stabilize the disease, and then the remaining pigmentation is treated with combination of Q-switched laser and a topical tacrolimus in moderate setting. And we published this our paper in Journal of Cosmetic and Laser Therapy, and these are few of our results. This is lichen planus pigmentosus since last 10 years, not responding to anything, and we just treated with 5 to 6 mm, 3 joules per centimeter square once a month for 5 sessions, and the pigment is completely cleared. There is little bit of confetti glycoderma on this area, but the patient is perfectly happy because she got her color back. And hence we started using it in day-to-day practice for LPP, and we got even in type 4, type 5, type 6 skin, LPP improves very nicely. Otherwise, this will persist for a long time. Another patient of LPP 5 sessions with a good clearance of the pigment. And this is a localized LPP. Again, biopsy proven, we stabilized the disease and treated with the same parameters, and just in 6 sessions, once a month, he's still under treatment, but he has a remarkable improvement in his pigmentation. Coming to the tattoo, I will not talk much about it, but Q-switch is still a gold standard for tattoo removal. I think Pico is going to overtake tattoo, but the cost of Pico is prohibitory. I'm routinely using where we are using perfluorocalin immediately after the tattoo removal, and we can do 4 sessions. Or if the perfluorocalin is not available, we can use R20 method, where you have to fire one, wait for 20 minutes to frosting to go away, then treat it with the same sittings for 3 times more. And that's called as classical R20 method. We use predominantly for amateur 1 or 2 colored tattoos this method. Larger spot size, irrespective whether it's a line tattoo or it's a figured tattoo, we use the largest spot size, minimum 6 to 7 mm, because 1064 is a forgiving wavelength. It will not harm the normal epidermis, and patients were generally treated once in a month. And these are the color. You can use it 532 for red and 1064 for black or gray color tattoos. These are forehead tattoos, very common in rural India. They required 1 or 2 sessions. These are all amateur tattoos. Another tattoo on forearm, just in 4 sessions, complete clearance of amateur tattoo. Another session, tattoo forearm. This is a traumatic tattoo after road traffic accident, and we treat it 1 month after the accident with a lower fluence and a larger spot, because these tattoo inks are placed in the epidermis, not majority of them are in the epidermis. So we used around 7 mm and 2 to 3 joules only. And just in 1 session, the entire traumatic tattoo has been blasted off. So careful patient selection and knowing the depth of tattoo definitely helps in treatment. Another like R0, these are mostly army recruits or airline recruits where they don't allow tattoo. They are always in hurry. So we treated with 4 sessions of R0. The patient depigmented. I was worried, but at the same time, we see the follicular pigmentation, and just in 2 months, there's a complete removal of tattoo with the ghost image. This is okay for army. Coming to the laser toning, what we heard about Q-switch laser is now basically the hardcore indications, but Q-switch laser is still expensive, and we can't use it in day-to-day our practice. The laser toning has changed that. Laser toning is a treatment method using 1064 wavelength in a Q-switch mode without carbon notion for melasma, pigmentation, and intractable scar. So it's basically for day in and day out problems. The principle is low fluence multipass technique. The traditional treatment is based on principle of selective photothermolysis, which results in destruction and death of the cell. In response to cell death, there is an inflammation which results in recurrence of the lesion. So the earlier text says melasma recurs badly after laser. But the high peak power, ultra short pulse duration, and a flat top beam of Q-switch laser results in destruction of the melanin in the target cell, but leaving the cell alive. And this has been called as subcellular selective photothermolysis. So basically, since there is no cell death, there is no inflammation, and there is less recurrence. I've been using it for daily OPD practices such as rejuvenation. The tan patient, they do come to it, especially in this age group. And along with our topicals, this works wonderfully well. Another patient with photomelanosis, you can treat it. If you see the forehead melanosis, which is very common in India because of the friction of on the forehead, okay, melasma, laser toning, although I'm using it, it's basically a third line treatment. I mean, when everything fails, your topicals, chemical peels, everything fails, we give an option of Q-switch laser to the patient, explaining that it may also fail. So whatever I'm going to show, they are the only successful patient. Out of 10 treated, I think 6 will not respond satisfactorily, 4 will respond satisfactorily. Another case of melasma from Dr. Sanjeev Aurangabadkar. This is my patient with a partial response. He was not responding to anything else. He had some topical steroid abuse also, but he did responded to Q-switch toning. Young woman in her pre-marriage age group with melasma and lot of acne. We treated with 11 sessions of laser toning, which is done in once in 15 days with a good clearance of melasma. Same patient with a good clearance of melasma. Melasma is a dicey situation, but the post-inflammatory hyperpigmentation is not. You can safely use laser toning for PIH. This is a patient of scald. She has a very sensitive skin, so any topical will not be possible for her. So we used it with laser toning once in 15 days for just 6 sessions to get the PIH cleared. Again, a melasma who has rubbed hydroquinone on her forehead and laser toning cleared her PIH. Post-chemical peel burn done in a parlor, and we did it with laser toning just in 3 sessions. She got a good response, but unfortunately I lost the patient for follow-up. Road traffic accident, it's a wonderful indication. You require just 1 or 2 sessions, and the long agony of 6 months of PIH is been taken care with just 2 or 3 sessions of laser toning in post PIH. Acne or acne excori, you can use it. Lip pigmentation, of course, you can use it. Tongue pigmentation, again, you can use laser toning to treat it. Coming to the third common indication, which we see in our practice, is acne. Acne constitute almost 60% of our daily practice. Variety of treatment available. Medical treatment remains the gold standard. Lasers are not substitute for gold standard. Physical treatments often complements the medical treatment and produces some remarkable results in management of acne. So the basic principle of how laser will act in acne, the P-acne produces endogenous photosensitizer. This porphyrin absorbs certain wavelength, and activation of porphyrin results in free radicals, which kills propionic bacterium acne. This procedure is being used very commonly with the help of LEDs, UV light, IPL, and number of lasers are being used. But 1320 and carbon assisted quasi-long pulse treatment, which I use in my practice. So this is basically a spectra, same thing using a Q-switch laser, where we apply carbon lotion, then give 1 pass with quasi-long pulse, that is 300 microsecond of laser, followed by 5 nanosecond and 3. So these are pre-marriage group treated with monotherapy or with spectra and topicals with a good clearance. Steroid-induced acne, again, spectra peel, very good results. Pre-marriage age group, just once in 15 days for 2 sessions, and she is good to go. Another patient of acne excori treated with same protocol with a nice clearance of her. Now, I'll not spend much on time on gold stoning, because another case of nodulocystic acne treated with spectra peel, and there is a complete reduction of acne. So post-acne erythema can be treated with gold toning. This has been available with my laser, that is Spectra from Deutronics. They have 595 in a Q-switch mode, which is a target. We know 595 is the target of the target's vessel, so they can be safely used in post-acne erythema. This is a new acquisition of mine, which is basically AdvaTX, which is a solid state laser producing 589, that's for vascular, and 1319 for acne, 2 wavelengths. It's a solid state. I have no conflicts of interest. There is no consumable, there is no dye replacement required, and it's very sturdy. Variety of indications, vascular, acne, acne scar, wrinkles can be treated with this machine. We know that 589 acne can be treated. The vascular wavelength can treat the acne erythema, and 139 1319 nanometer targets the dermal vasculature and sebaceous gland to treat the acne. And this is with monotherapy in a pregnant woman. We can treat that with a due consent and explanation. We can treat acne in pregnant woman also. This is monotherapy without any topicals or anything, just with Advatx, and just 4 sessions once in 15 days with a good clearance of acne. Post-acne erythema, again 2 sessions once in 15 days with a good clearance of post-acne erythema. Acne with pigmentation, you can use 595 with a good clearance. Another patient of acne, and we can treat once in 15 days for 3 sessions to good control. And what we found that once it is been treated with 1319, the remission lasts for a long time. Coming to the next part, ablative lasers. I'm not going to spend much of time because we all know how they work and how they we use. They are used extensively for warts, adnexal tumors, skin cancers, excisions, vitiligo surgeries, resurfacing, everything. Coming to the fractional lasers, although effective, ablative lasers has their limitation. There's a long downtime, lot of complications not indicated in our skin. Fractional lasers are being, and they less used in Indian context for treatment of scars and rejuvenation. The fractional laser, the concept of instead of treating the entire skin, you fractionate the beam, go deep into the skin and treat only 5 to 20% of your skin with the fractional laser. The concept has changed from bulk heating to a fractional heating and ablation. It is predominantly used for scars, anti-aging, and variety of dermatological diseases. Scars, a scar is always scar, we know that. We can improve it more functionally and aesthetically, and thereby rearranging the more inducing collagen and improving the epidermal component of the scar. I use ECO2 fractional laser. Generally, I don't use it much for the scars, and I'll come to that later, because even if with say a fractional CO2, the risk of complications still remains there. Scar marks, the laser marks can be there. There is a downtime associated with each sitting of almost 7 to 10 days. And we are going to typically use 20% or 25% of density and energy what white skin is being using. So our results are going to be lesser than what is being showed or displayed in their textbook brochures. But this is a good patient who has been responded nicely with fractional CO2. I used microneedling RF predominantly for treatment of scar, and the entire concept changes from light to electric current. MNRF has revolutionized how we treat scar in pigmented skin. The difference is here we are using an electric current than a light, which is delivered through the needle at a selected depth of the dermis. We can select the depth on the handpiece. The collagen and the dermal vasculature offer resistance, and by Faraday's laws, the heat is generated because of this resistance, the electric current converted into heat, and we get neocollagenesis. So I use predominantly for scars, acne scars. The advantage here is there is no downtime, hardly a downtime of 1 day. You can, since radio frequency is color blind, you can be as aggressive as you want, and you can go very deep with that. So this is a patient which has been treated with MNRF once in month for 3 months with a good clearance. Again, ice pick scar also responds well to microneedling RF. You have to select the depth of the needle deep enough and treat it. Another patient, this is a really a bad patient. If you can see, she has CO2 laser marks. This has been treated previously. So we just used MNRF, and you can see the remarkable difference even in these deep and punched out scars. This has been treated for 6 sessions, and we got a satisfactory results in her. Another patient of MNRF with a badly scarred face, and we could almost reduce it by 50 to 60%. And this is just in 1 session of MNRF. Almost all the scars has improved to a great extent. So MNRF is my treatment of choice for acne scars. Another patient of acne scars with PR, we treated with MNRF and PRP. All her acne scars, seborrhea, acne, and the linear surgical scar, all of them, there is a pan-facial improvement in this patient. Chickenpox scars are easy to treat with fractional CO2. You can just use 1 or 2 sessions of fractional CO2 for chickenpox scars, and they do improve. Another case of chickenpox scar. This is courtesy Dr. Chandrasekhar. It did improve. Surgical scar, we used microneedling radio frequency and superficial fractional radio frequency because it is near the eye. She was not ready for lasers. So we used radio frequency to a mild improvement her in scar. Traumatic scar again improves well. This is one of the great lasers for used in traumatic scar and surgical scar, 1550 RBM glass laser. I've started recently using it and I found it is extremely helpful. It's relatively painless than CO2 and MNRF, and it especially works well for superficials and surgical scars. So this is another case of surgical scar which has been treated with 1550, and we started this at the day of stitch removal, just once in a month for 3 months, and with a great improvement in her scar. Coming to the last topic of today's discussion, which is again my favorite, the excimer laser or monochromatic excimer light. I believe this is a dermatologist laser. Every single dermatologist in subcontinent should have this. Basically, excimer is basically an excited dimer. It uses 311 nanometer of xenon chloride. It has revolutionized, at least in my clinic, management of many such diseases such as vitiligo, alopecia areata, and psoriasis. Many new indications are added in day to day, like granuloma annular, prurigo nodularis. You can use it. It works by inducing melanogenesis, basically by melanogenesis inducing apoptosis of T cells, alteration of the cytokines, and it's an immune modulatory measure. The laser is expensive, it is very bulky, you need a frequent changes of gases. To overcome these problems, monochromatic excimer light is being introduced. Because the light produced by this system is not coherent, the phase and amplitude are not constant, these systems cannot be defined as lasers. They do, however, have a medically relevant characteristics of an excimer laser, that is monochromatic radiation at 308 nanometer. And that's what we exactly want in treatment. The substantial difference is, I'll not go into the detail, but the laser, the xenon chloride gas is encapsulated in a glass tube, which eliminates the requirement of glass consumption. And this laser has a long half-life. Typically the lamp lasts for 1000 hours, and one patient requires at least 20 to 30 seconds of treatment. So you can see, you can use it safely for 10 years without any consumable. And there are enough studies now to show that the xenon chloride laser and xenon chloride lamp, there is no much difference in the outcome of the treatment, except for xenon chloride lamp induces more erythema than chloride laser, but that is perfectly absorbable in absolutely normal in pigmented skin. The spot size, the pore density is less in lamp, but that has been compensated with the large spot size. So 25 square centimeter is the spot size available with my monochromatic excimer light. So that means you can treat the size of palm in just 2 shots, and that takes around 20 to 30 seconds. So the optical power is especially even more with xenon chloride lamp, and the weight is just less than 1 kg. So your technician can use it without tiring it. It can be used in localized vitiligo. If you see, just in 32 or 15 to 32 sessions, you can get a good repigmentation, which is cosmetically also very elegant. And as compared to PUA, where you have more of hyperpigmentation. You can treat difficult to treat sites such as nipple, angle of mouth, or inside the ear, which is absolutely not possible with narrowband UVB or photochemotherapy. And you can still treat it with these difficult to treat. Even the lip vitiligo do improve with monochromatic excimer lamp, and these are being patient treated with once or twice a week with 40 to 40 sessions. The upper eyelid is a piece cake. I mean, they just respond in 10 to 15 sessions, but the lip lesion also improved in around 26 sessions. Acral vitiligo is a very difficult condition to treat. I'm trying it with an excimer, and we are getting some good results, but it's again, it's an extremely difficult condition to treat with all of the phototherapy. Now, this patient I've been treated with melanocyte keratinocyte transplant followed by an excimer laser with a good clearance of her vitiligo. Generalized vitiligo, you can treat it with a combination of narrowband UVB and excimer for the exposed area. Here I treated face with excimer and the body with narrowband UVB, and very good clearance of her vitiligo. All these patients are being treated with a simultaneous application of either a Saturday Sunday mini steroid pulse or as a oral azathioprine to get a good clearance in their vitiligo. And this is really a life changing for this patient. Unfortunately, her lips didn't improve, but the rest of the face improved very nicely with just 25 sessions of Excimer. Another patient, 45 sessions of Excimer, and he did improve. What we do is we use a stencil according to the size of lesion and then eradicate that area so as to prevent the perilesional hyperpigmentation. And they are being treated with in addition of topical tacrolimus also. Segmental vitiligo, Excimer is a game changer because we know that segmental vitiligo is very, very difficult to treat. And if you start the treatment early, especially within the 6 months of appearance of vitiligo, you can almost get complete clearance without surgery of segmental vitiligo, also with Excimer and topical tacrolimus. The typical sites such as labia majora, lips, chin, any area can be treated with. And even if it do not respond completely, you can definitely reduce the size of lesion so that your surgical modalities will be very less traumatizing or painful for the patient. And we published our article in Journal of Clinical and Aesthetic Dermatology, 308 nanometer monochromatic Excimer light and topical 1% ointment in segmental vitiligo with a good clearance of vitiligo. Halonivai, again, it's very difficult. I am sure that it must be common in Bangladesh also. And what we do is remove those nevi cell from the lesion. But you can use your Excimer and just in 8 to 10 sessions, it get repigmented without removing nevi. So that's very encouraging. And we follow this patient dermoscopically, as it is malignant melanoma is extremely rare in our patient. And we do not see any chance of malignant melanoma in this. And Halonivai as large as this, the patient refused surgery. He did not wanted surgery. So we treated with an Excimer and just in 20 sessions, there's a complete repigmentation of the Excimer. You can treat it with psoriasis, especially flexural psoriasis, with topical tacrolimus. Just in 10 sessions, once in 2 days, you can treat it. Palmoplantar psoriasis, because it has mast cells, it's a very good antipruritic mechanism, and you can use it for treatment of, along with topical steroid, for treatment of palmar and of course the plantar lesions of palmoplantar psoriasis. And definitely, what I found is even with systemic therapy, it's very difficult to control the itch on the palms and sole. And this patient report you with a very happy face that their itch has been very nicely controlled with addition of Excimer, and I use it routinely in this patient. And here the 25 square centimeter size spot size comes into place because she or he requires just one shot to treat this area, and that becomes a cost effective also. Localized pustular psoriasis, this is the only one patient, very problematic patient with a lot of comorbidities, and she was not ready for any systemic treatment. I just as a chance tried Excimer on this patient with topical clobetasol, and she responded very nicely. Even in pustular psoriasis. Alopecia areata in children, again, a treatment of choice in my clinic for alopecia areata. Most of them are treated with topical mometasone and Excimer once a week for 18 to 20 sessions, and almost you get complete regrowth, even in ophiotic pattern. Even in ophiotic pattern, you can get a good growth. We know alopecia totalis, she's been treated with extensive courses of steroids and cyclosporine, did not respond. So we combined here some with azathioprine and Excimer laser with a good regrowth in a child just with topical mometasone and Excimer, good regrowth, which has been maintained for a long time. This is basically, we induce supraerythemogenic doses to create more of an inflammation at the site, which is acceptable by the patient and tolerable also, but it induces a very good growth in these patients. Coming to the 2 last slides, complications. We know every medical treatment has complications, so we have to avoid a complication. The skin response to the laser exposure are mild to severe reddening. Blistering and charring is always needs to be avoided. Depigmentation is disastrous for the patient and for the physician. Ulceration scarring is also disastrous. By using a good external cooling device, you can definitely take care of, and of course by selecting the correct parameters and using an external cooling device, you can take care of this. To conclude, lasers are effectively used to treat many different aesthetic and dermatological conditions. Proper use and patient care often produces satisfactory results for patients and physicians. Thank you very much. Be safe and be at home. Let there be a light. Thank you, sir.
Thank you, Dr. Swapnil Shaha.
I hope I have not exceeded my time by a large difference.
Thank you. Thank you, Dr. Swapnil Shaha, for your brilliant presentation.
Thank you, sir.
And what you have done, it is wonderful. And maybe we have made you tired of giving a very long presentation, because use of laser in dermatology, it is a vast subject.
Yes.
Rather, it should be divided into smaller parts.
Yeah, exactly.
Yeah, case by case or laser by laser. That could be better for you and also for the audience.
Yes, sir.
But even then, you have done a wonderful job. Thank you, Dr. Swapnil. Yeah. Now, I like to invite our participants for joining question answer session. Maybe we have a good number of questions for Dr. Swapnil. Let us start with the first one. Advantage of cooling device. I think along with many different kinds of laser procedure, one should have a very cooling device.
Yes.
I'm right, Dr. Swapnil?
Yes, sir. Because what I found is whatever the inbuilt cooling offered with most of the lasers is insufficient for our skin. I mean, then we have to limit our aggressiveness because of risk of complication. Now, if you have an additional cooling device like a Zimmer or even simple pre and post cooling with ice packs, that I mean gives us a chance to treat the condition aggressively, so that we can really not only treat it safely, aggressively, but effectively also. So a cooling device is definitely, and I mean, it's a luxury, but then I feel it's a good thing to have.
Okay, thank you, Swapnil. Next question is, in hair reduction, use of diode 810, time interval between 2 sessions, required how many sessions, maintaining therapy required, if how many sessions per year? Dr. Amrish, can you please make your comment? That is regarding 810 diode laser. How many sessions and interval of session, and how frequently?
So the question is, I mean, broad. I mean, you have to know that which area you are treating. Suppose you are treating a face, any session less than 4 weeks, you have to look at the anagen of that area. The general rule is the anagen above neck is 1 month, 4 weeks, and below month is around 6 to 8 weeks. So any session before that is not required. I mean, there should be a gap of 4 weeks. So initially we used to say that you have to treat it once in 6 weeks, once in 8 weeks, or once in 12 weeks, whatever. Now I don't tell my patient like this. Now what I tell my patient is, come back when you feel that you require a treatment. It should not be within 4 weeks if it is on the face. So if you are going to come back after 6 weeks, that's okay. If you're going to come back after 8 weeks, it is still okay. If you are going to come back after 12 weeks, it is still okay. And if you don't need to after 12 weeks, generally you do not require a laser hair removal. So I give my patient a liberty to choose their treatment time. I mean, because we know that with evolving therapy, it is impossible to reduce the hairs completely. So it's like maintaining their remissions for a long time. So the treatment is depends on the patient. Generally between 6 to 12 weeks.
12 weeks, yeah. And also, if there is any hormonal abnormality along with the hirsutism, then also the length of treatment will depend.
Depends, yes, sir.
Yeah. Okay. Next question is whether the laser use is safe in photosensitive patient.
If you strictly ask me, like photosensitive means, let's say an example of SLE, systemic lupus erythematosus, or polymorphic light eruptions. These are the patients who are actually sensitive to an ultraviolet rays of UV spectrum, the light spectrum. They are more sensitive to the UV rays. They are not much sensitive to the visible light, and absolutely sensitive to the infrared laser. And most of the lasers which we use are in the infrared range, except excimer. So excimer strictly no, but if they want an hair reduction, you can definitely use them.
So other than ultraviolet range, we can use the other lasers.
Other lasers.
Safely. Yeah.
Yes.
And after treatment of nevus of aorta, is it recurring? Recur after?
Yeah. So I have treated more than around 60 to 80 nevus of aorta. My friend has treated almost 200 to 250 nevus of aorta in Hyderabad. And till now, we have not seen a recurrence. I mean, we are not that experienced to say what happens after 30 years of practice. But in our 15 to 16 years of practice, we have not seen a recurrence as such.
Okay. And how many sessions it may take?
So
number of sessions?
Yeah, so we take around once in 3 months. So if you treat once in three months, it depends. General sessions are between 6 to 10.
Okay, 6 to 10. Yeah.
6 to 10.
Sometimes I have seen somebody have practice of using laser, Q-switch laser in nevus of aorta every month. So is there any?
No, if you treat every month, you require around 15 to 17 sessions for a good clearance, because here we have to understand the mechanism how which laser works. It is just breaking down the pigment into a smaller particle. The macrophages has to take away these particles from the dermis, and for that they'll require time. So it's best to wait for 2 to 3 months between.
2 to 3 months. Yeah. It is not wise to use monthly.
Definitely not for nevus of aorta.
Yeah, sure. And next question regarding IPL in the treatment of melasma. Do you recommend that?
I don't have a personal experience of IPL used in melasma, and I feel IPL acts on epidermal component only. It does not act on dermal component. Epidermal component can be treated with topicals. So IPL adds nothing for melasma actually.
Yeah. And also there are other options, better options for melasma. So better not to use IPL in melasma. The question is regarding melasma, which is the best chemical peeling, microdermabrasion, laser therapy. So which is the best? So answer is very difficult.
Melasma is a sleeping giant. I know it's a sleeping giant, and you use whatever which is non-traumatic in treatment. I don't use much of microdermabrasion in melasma. Peeling is second line. I mean, if the patient fails to topicals, we used a lot of peeling agents like glycolic acid or even azelaic acid or combination peel containing kojic, trichloroacetic acid. And if they don't respond to that, then we add lasers if they are ready, the patients are ready with a proper explanation and consent.
So maybe laser is the last option.
Laser is the last option.
Yeah. Okay. What is the rate of relapse in LPP after laser treatment?
We presented a case series of around 20 patients, 30 patients for LPP. Each of them has been biopsied, and we did a laser only when there is no dermal infiltrate. I mean, there is no blazer BMZ inflammation. The band-like infiltrate is not there, and then only we treated. If the patient do not use hair dyes, if they follow the sun protection, we have not seen any recurrences till now. I have seen one recurrence of LPP during the treatment only. I mean, not after the treatment. So after the second session, what I seen is the pigment is coming back. And then we asked the history, and there was a history of dye application to the scalp, which of course precipitated it. So we stopped.
So aggravating factors and use of sunscreen is very important.
Of course, sir.
To prevent the relapse.
Yes.
Okay. Yeah. Next is regarding vascular laser in keloid. I think in keloid there is role of vascular lasers, pulse dye laser.
In early keloids,
vascular elements is there.
No. If the keloid is early, the scar is early, if there is erythema, you can use it, a vascular laser.
That is where there is some vascular component is there.
Yes,
then use a pulse dye.
Use the pulse dye. I found 1550 works wonderfully well in keloids. I have not covered it because of time lag, but 1550 works wonderfully well in keloid because it is less traumatic laser. I mean, and you have to always combine with an intralesional kinopod.
Right.
It's never been a monotherapy with laser.
If it is not early, if it is too late, that is a chronic scar then. In case of a chronic scar or keloid, where
Yeah.
there is a little vascular component. In
Yeah,
that case,
that's why I said 1550 works well in
1550.
those. Yes.
So 1550, is it fractional?
Yeah, it's a fractional
Yeah.
RBM glass. It's a
RBM
fractional.
class. Yeah. Okay. Next question is treatment use of X-laser plus laser Q switch 1064. In case of melasma, X-laser, do you have any idea of X-laser laser? That is one laser from Italy. So it is a particular laser brand, so it is not possible to give any remark. Yeah, if you don't have any experience of using that laser particular, so you cannot remark. X-laser, it is an Italian laser.
I know about it, sir.
Yeah, it has
It's a
Q switch and
but
DX.
it's not a, it's a Q switch NDIAC. I believe it's a long pulse NDIAC with an IPL.
Yeah, it is a multi-system. So it has also Q switch, it has long pulse. You can add many different types of.
I've not used it.
Yeah, okay. Next, treatment of acne and rosacea with pulse dye laser. What is your experience?
So I don't have an access to a pulse dye laser, a standard pulse dye laser, but I'm using AdvaTX, which is a solid state 589 wavelength, and then there is a Flexis system, which is again 577 nanometer, which are vascular. If you have an inflammatory acne, it works wonderfully well. There is no question about it.
Yeah. Next question is regarding the eczymal laser used in prurigo nodularis.
It works well.
Any idea?
I have not shown the photographs, but I have a good number of patients of prurigo nodularis treated with combination of topical steroid and eczymer, and it works well.
Yeah,
and it works well.
Eczymal laser, that is 308.
Yeah, 308.
Yeah. So it is effective in case of prurigo nodularis.
Yes, because it has a very potent action on mast cells. It's a very good antipruritic agent in itself.
Yeah.
So it, by reducing itch also, it's a good modality.
Yeah. So 308 eczymal laser and 308 eczymal light. So what should be the proper to use the either eczymal light or eczymal laser?
No, sir. As I mentioned, eczymer laser came first. The problem with eczymer laser, it's very huge.
It's very costly.
It's very costly.
Very heavy. Very heavy.
And you need to change the gases very frequently.
Right.
And it's a very unstable system. There is plenty of breakdowns with lasers.
Yeah.
So to overcome that, they have formulated a monochromatic eczymer lamp.
Right. Yeah.
And at least there are 5 papers which are studied split body study comparing a monochromatic eczymer light with monochromatic eczymer laser.
Yeah.
And they found there is no difference in efficacy and safety. And
so it is better to use eczymal light because it is very cheap and it is very lightweight.
Yes, sir. Yes.
Yeah. So eczymal light can be used in case of prurigo nodularis.
Yes, sir.
Instead of eczymal laser.
You can use it.
Okay. Yeah. Okay. So I have seen there are so many different brands of eczymal light, and very cheaper brands are also there from China and from Korea. So do you have any recommendation so that we can have an eczymal light?
Okay. So I'll tell you, I'm using, I have 2 eczymer lights. One from, I earlier used for, that's from Quantelderm, that 308. And now I'm using Claris's eczymer, that Exiplex. Now,
Exiplex from Korea?
No, from France.
From France, yeah.
Claris's. So
what is the price of that machine?
In Indian rupees, it costs around 12 to 13 lakhs, sir.
13 lakhs. Okay, yeah.
Okay.
But you know, there are some cheaper brands that they're from Korea.
Chinese machines are there. No, most of them are Chinese, which cost around
1 lakh,
1 lakh, 2 lakh, 3 lakh rupees.
Right.
So
does it work?
Yeah, it do work.
Okay.
It do work. It's not like it doesn't work, but it's not 308 pure, sir. I mean, it's a little bit broader range of light. So
still it is better. Still it is better than UVB.
Yeah, it's better than UVB.
Yeah, better than UVB, and particularly for localized area of psoriasis, vitiligo, small lesions, we can use
But if you
eczema light.
calculate the total cost you are going to spend, you are going to spend the same amount of money only in installments, because this lamp has a very small life, like 100 hours, 200 hours, as against this 1000 hours. So generally, yes.
Okay, thank you. And in vitiligo, dose of azathioprine, please.
So we generally give low dose azathioprine in vitiligo. We use 50 milligram, 25 in children and 50 in adult. In very few, very aggressive patients, we go up to 100, but not more than that, never more than that. Generally 50 to 100 milligram of azathioprine works wonderfully well in vitiligo.
Daily or in?
Daily.
Daily. For how many days?
How many days is a difficult question to answer, but for generally 6 months to 1 year.
Okay, yeah. Is there any side effect out of that?
Of course, you have to monitor the CBC and LFTs regularly. If you have an access, you can get its TPMT levels, thiopurine methyl transaminase levels before starting azathioprine. That will help you in establishing the dose. But the test is expensive, and most of our patients don't afford it. It costs 5,000 rupees in Indian rupees. So
at least once in a month.
No, just before initiation of azathioprine.
And thereafter every month or every 3 months?
Every month is CBC and LFTs, that's all.
Okay, yeah. And do you ever recommend methotrexate in the treatment of vitiligo?
So there are a lot of studies comparing, Indian experiences comparing methotrexate against azathioprine. What we found, azathioprine works better than methotrexate in vitiligo, in my opinion.
And in terms of safety measures?
I think it's equally safe. Azathioprine, it's equally safe. It's a safe drug. You just need to do a regular monitoring, and that's all.
Okay. Now the next question is regarding nevus of aorta affecting the conjunctiva and cornea, that is involving the eye. Do you have any choice of treatment for that?
Yes, there is a report in ophthalmology literature. I am not remembering the exact laser, but it's an ophthalmic laser. They have used it for pigmentation of conjunctiva also, and they have successfully reported. I'm not offhand, I'm not remembering the wavelength, but the ophthalmology literature, this is in 2019. They have used it for treatment of conjunctival pigmentation because of aorta with successful clearance. If interested, they can mail me. I'll give you the reference.
So have you ever treated any case of nevus of aorta with eye?
No.
Involved? No.
No, inside the eye, no.
Yeah. But so far I know some ophthalmologists are also using Q-switch NDA laser for their ophthalmological conditions. So maybe they know better about the
I'm definitely know that it's not Q-switch NDAC for sure. It's a different wavelength. It's a very superficial wavelength which will not penetrate deep, because if you use 1064 inside the eye, he is going to have scotomas. It's not
right. Okay, one question is regarding the treatment of alopecia totalis. Which drug is the best option to treat with?
So alopecia totalis, we generally use cyclosporin. That's the commonest drug which I used for totalis, and I found it is efficacious, very well efficacious. The only problem is there is a chance of relapse after stopping cyclosporin. Another thing which we use is contact immunotherapy with DPCP. That's very good. We get it commercially also. So DPCP, contact immunotherapy, or cyclosporin, and Excimer, especially in case of children's. If the children are there, we used Excimer.
Okay. So combination of Excimer light as well as the drug.
Yes, generally if I'm using Excimer, I don't use cyclosporin. I use Saturday Sunday steroids, minipulse oral minipulse steroids with Excimer.
Minipulse steroid, what is the dose?
So generally it is 1 milligram per kg, but we use around you can say it's a micropulse. You use 3 tablets of betamethasone on Saturday and 3 tablets of betamethasone on Sunday. That is 3 milligram of betamethasone on Saturday and 3 on Sunday for first 3 months, then reduce it to 2 and then reduce it to 1. That's what
3 milligram is enough dose?
I think it's enough, sir. 5 milligram has been recommended,
Yeah,
but I order, especially when we discuss, we found 2 to 3 milligram is
2
good enough.
milligram is good enough.
Good
Okay.
enough for inducing stability. And this is personal. I mean, the dose described is 5 milligram.
Okay. Okay. Thank you. Next question is, what is the parameter of Q switch NDA laser in case of facial rejuvenation?
So we use a laser toning method. So whatever the spot size you have, 8 to 10 mm of spot size, the fluence between 1 to 1.2 joules, the frequency between 5 to 10 hertz, and 3 passes all over the face.
Okay, so so what is the difference between laser toning and carbon peel?
The carbon peel is basically an external chromophore. So we know that laser toning acts well for dermal component.
Okay.
If you want an epidermal rejuvenation, because 1064 is absorbed very rare, little by epidermis, you don't get much of epidermal rejuvenation.
Okay.
Now you apply carbon on the face, and if you use 1064, the carbon will act as an external chromophore and it will blast it off, the 1064 wavelength. And you will get an epidermal rejuvenation along with dermal rejuvenation with the second pass.
Okay.
Secondly, you can use carbon peel for inflammatory acne, where you use carbon lotion all over the face.
Yeah.
The first pass is given with 300 microsecond, that is quasi long pulse NDR, which is most of these Korean Q switched have with it, like Spectra or anything.
Okay.
That will gently hit the carbon. The heat is transmitted to the sebaceous gland, and they had been occluded. And the second and third pass with a Q switch mode, which will blast away the carbon, and you can use it in acne in similar way.
Okay, so in case of carbon peel, we can use 1064 or even 755 alexandrite.
If you have Q switch alexandrite, you can use it, but Q switch alexandrite it's risky for our skin, sir.
Okay, so better to use 1064,
1064
for laser peel, that is carbon peel.
Carbon peel.
It can be used for acne as well as for open pore.
Open pores for generalized rejuvenation of face, pigment improvement.
Okay, and for dermal pigmentation, better to use 1064 with there is bigger spot size and very there is low dose. Yeah.
Yes, sir. Yes, sir.
Yeah. Dose should be 1 to 1.5, something
1
like
to 1.5 joules.
Yeah. And spot size 8 to 10 millimeter.
8 to 10 millimeter.
Yeah. And how many days interval?
Once in 15 days. The classical toning is described as once a week, but we found if we do once a week, you will land up with the confetti leukoderma.
Yeah.
So it's best to do once in 15 days.
Yeah. And if my target is epidermal pigmentation, then can I use 532 instead of 1064?
For a localized lesion, yes, sir, you can use it. Not pan-facial rejuvenation. I mean, because it's a very risky wavelength.
Right.
You will land it with pigmentation, either hypo or depigmentation or hyperpigmentation.
So better to use 1064.
Yes, still better to use. There will be more number of sessions required, but still you can safely.
And it is safer. Okay. And next question is, fluence of Q-switch NDA laser should be used in hair reduction to prevent paradoxical hypertrichosis. What fluence of NDA laser should be used in hair reduction? NDA, maybe long pulse NDA.
Yes.
Question may be long pulse NDA. What should be the
So the paradoxical hair growth is an untoward side effect. One of the theory is if you use a suboptimal fluence to treat hairs, they'll get inadvertently excited and you will get a growth. But this is just one of the theory. Even if you get a paradoxical hair growth, you have to treat with LHR only. I mean, whatever the fluence depends on where are you treating, what are the skin type, what is the hair type. The general rule is thicker hair will require longer pulse width and less fluence. The thinner hairs will require a shorter pulse width and more fluence.
Yeah. Suppose in our type 4 or type 5 Fitzpatrick skin type, if I go to use the long pulse NDA 1064, then what should be the initial starting?
Again, it depends on machine, sir. I mean, I'm using, my protocol is I'm using Candela's long pulse NDR, gentle air. So I have 15 mm spot size. So I start with the 15 spot size. I choose the pulse width between 20 milliseconds and fluence between 35 to 40 joules per square centimeter.
35 to 40 joules
per square centimeter. That's me. My start.
Less fluence may just cause the paradox. Yeah, yeah. Okay. And there are so many questions. No problem. So is the laser safe in pregnancy?
If you ask scientifically, it is safe in pregnancy. I mean, there is no harm because we know the depth of penetration is not even subcutaneous tissue with most of the laser. So pregnancy, it will not affect the pregnancy, but there will be a lot of
Suppose Q switch NDX for laser toning. Is it safe in pregnancy?
It is safe, sir, because it's not like laser is not, it's a simple light. It's not an ionizing radiation. It is not going to harm the fetus in any way. The problem is with the patient's attitude. If something goes wrong with the pregnancy, they will first blame your laser for that. So I select pregnant patient for facial rejuvenation if I'm convinced with their mental understanding that they are understanding what I'm speaking.
Okay.
And then we will do it.
Yeah. Okay. And in case of Becker's nevus and Halo nevus, is it totally curable by laser? And if possible, which types of laser is suitable?
So Becker's nevus is absolute no. I have no experience. I don't treat Becker's nevus because it's extremely difficult to treat. The published literature says that you can treat it with erbium glass, erbium YAG resurfacing, that you completely ablate the nevus, which I feel in our skin is going to land up with pigmentation. The post-operative results will be more bad than the precondition. So I don't treat Becker's nevus. Halo nevus, yes, you can treat with an excimer, and that's a very easy treatment.
And also Becker's nevus, it may have hairs also.
Of course.
So hairy part and pigmented part, it is very difficult to cover both.
Yes, yes, sir.
Okay. What lasers for skin brightening? For skin whitening and skin brightening, also there is laser toning with the help of 1064 long pulse.
Yeah, you can use, I'll give you a list of lasers, sir. You can choose whatever you want. You can use a laser toning. You can use a low dose erbium, fractional erbium YAG. You can use a low dose fractional CO2. You can use a thulium laser, a fractional thulium laser, which has been very popular in Western world for glow and epidermal pigmentation.
Yeah, yeah. That is what is the wavelength of that laser, thulium laser?
Thulium is 1970, 1970.
1970. Yeah, it is a very new device which has been introduced.
Yes, sir.
Recently. Yeah.
Yes, and it's a very good device for epidermal rejuvenation, like glow and everything.
And one question regarding the treatment of onychomycosis. Treatment with laser. Can you please give a little brief about that?
So it's a very good indication. I am using it all the time. Onychomycosis, the principle here is most of the fungi which cause onychomycosis are thermophilic. You raise the temperature to around 60 to 80 degrees and they will get killed. So you can use plenty of laser to treat it. You can use your long pulse Nd:YAG laser. You can use your Q switched Nd:YAG laser. You can use your fractional CO2 for better drug delivery. I generally used Q switched Nd:YAG laser in a quasi long pulse mode. So I use 300 microsecond of Q switch Nd:YAG, 7 mm spot size, 14 joules per square centimeter. That can be long pulse Nd:YAG also. 7 mm spot size, 14 joules per square centimeter, and 0.3 millisecond pulse duration. 80 shots per minute per nail. 80 shots per nail, and that's what I follow. Generally, it is to be done once in a month for 3 to 4 sessions. That's all.
Once in a month for 3 to 4 sessions. And if the interval is even less, suppose 2 weeks or 3 weeks,
you can use it, sir. There is no harm using it.
Because somebody like say like this. There is long pulse Nd:YAG 1064 every weekly for 6 to 7 sessions.
Maybe, sir. So that's what it comes to. If you use 6 to 7 sessions and once a month for 3 to 4 sessions, that's a cost effective. The duration of treatment remains the same.
Yeah. And also, Q-switch NDA can also be used in case of
Yes,
onychomycosis if there is a color pigment.
No, even if there is no color pigment, you can still use it, sir, because every fungi has some color in it. So
Color.
you can treat Q-switched NDA.
So which one is better, Q-switch NDA or a long pulse NDA?
So there is no comparative studies available. I use both Q-switched and long pulse both in my practice. So I'm really not able to comment which is better.
Okay.
Q-switch is fast. It's easy to use. That's the only advantage of Q-switch.
Q-switch.
Yes.
Okay. Yeah. And once in a month.
Once in a month. Yes.
Okay. Okay. Yeah. Another question: efficacy of CO2 laser in Acanthosis nigricans.
I think Acanthosis nigricans CO2 can work, but it's never be a monotherapy because Acanthosis nigricans reflects insulin resistance. It is seen in obese, metabolically compromised patients. So the treatment should be holistic. The laser is just a very small part of treatment of Acanthosis nigricans. Reduction of body weight, correction of hyperinsulinemia should be the cornerstone of management.
Okay. Okay. Maybe we are coming to the end of this session. I have a question. You have shown one slide of Dr. Sakia. He has treated one oral cancer with hair element by using diode.
It's not hair oral cancer treated.
Yeah.
It is basically a cancer of cheek which has been surgically removed, and we have used a flap from the hair bearing area to create the oral mucosa.
Okay.
So because of that, there is a hair growth.
Okay.
And to reduce that hair growth, he has used a diode.
Diode laser. So diode by contact or non-contact?
Non-contact, because you can't contact inside the mouth most of the laser. So he just fired from the distance.
So we know that diode always it will work by contact, by using a contact.
Yes, sir. Yes, sir.
So how it is done by non-contact?
No, basically it works by contact means you have to do a contact for better absorption.
Okay.
So what he did is, since there is no competitive chromophore inside the cheek, he used an high fluence, open the mouth retractor and just fire from a distance.
Okay.
So the fluence delivered is not correct, but his job was done. Actually, the hair has been reduced.
Yeah. Thank you, Dr. Swapnil. Just one more question from my side. You have described one laser with 589 and 1319 wavelength. I want to know a little about this particular laser. Which company and what is the price?
Okay, just a minute. So this is basically an ADVA TX. The machine name is ADVA TX. ADVAT X, ADVAT X.
Yeah, okay.
So it is basically from Danish. It's a Danish company made in Denmark.
Yeah.
Basically, it has two crystals, solid crystals of ND YAG.
Okay.
One crystal produces 1319 wavelength, and the other crystal produces 10164 wavelength.
Okay.
Now these two wavelengths are passed through a coupler, a lens. Like similarly, what we do in 532, we frequency double it.
Okay.
When we double the frequency of 1064 through a KTP, we will get 532.
532. Yeah.
Similarly, they did a frequency tripling. They tripled the frequency.
Okay.
And with combination of 1064 and 1319, they produced 589 out of it, and 1319 out of it.
Okay.
So 589 is used for vascular lesion, and the 1319 is used for acne and acne scars.
Okay.
Now it's a theoretically a wonderful concept. The only problem is it fell short in treating port wine stain as compared to the standard pulse dye laser, because the pulse width here is in milliseconds.
Okay.
The pulse width starts between 20 to around 80 milliseconds, and for port wine stain you require something between 0.3 to 0.5 millisecond. But the advantage here is it becomes an extremely safe treatment, extremely painless treatment. You can start with the children as early as possible.
Okay.
So I found that it's a wonderful treatment. It's an expensive laser, although, but the advantage is there is no consumable, there is no dye replacement, which costs itself 3 lakh rupees per year.
Yeah.
So this machine cost somewhere between 40 to 45 lakhs in Indian rupees.
So it is a liquid laser.
No, it's not a liquid. It's a purely a solid state laser.
Solid state laser. Okay. Yeah. Thank you very much, Dr. Swapnil Saha, to be with us for a long time.
Thank you. Thank you so much. I
Thank you
enjoyed
so
it.
much.
Thank you so
Yeah,
much.
yeah. Maybe we have come to almost the last
and-
end of today's webinar. Dear audience, I think we all have learned many things from Dr. Swapnil Saha, from his presentation, as well as from this question answer session. In this session, he has done a wonderful job giving answers to so many questions from our learned audience. Now, I am going to invite our panel of experts one by one. We have today among us 4 panel of experts with us. So I'm going to invite the first panel of expert, that is Professor Brigadier General Retired Dr. Abdul Latif. He was the professor and ex-head of Department of Skin VD in CMH Dhaka. So may I invite Professor Brigadier Dr. M.L. Latif to give your valuable comments and remarks, please.
Oh, thank you very much. Respected President, ACDB, distinguished speakers, and learned participants. Assalamu alaikum. Professor Swapnil has discussed elaborately. I will share my experience in my center because laser has become a very popular nowadays. And when we medical treatment fails, many of the cases like pigmented lesion, as you have heard, vascular lesion, benign cutaneous lesion, hair removal, rejuvenation. So in that case, laser has become very popular and gives a satisfactory result. Now, first of all, the main problem in our day-to-day life we are facing, that is pigmentation. So in our center, we are using Q-switched India laser, mainly the Medlight C6. Here we are treating many congenital melanocytic nevus, nevus of Ota, Hori nevus, freckles, and tattoo removal. All are excellent result, as you have heard in the lecture session. I will not mention details, but nowadays it has superseded that picosecond laser that gives a very good result. And you can treat, many of us asked melasma even, but other than that, Q-switched India laser is not a good laser for melasma or other. For post-inflammatory hyperpigmentation, acid dermatosis, and in addition, other laser treated by the Q-switched India laser, it takes very short time, and patient is satisfied with this picosecond laser. And with our experience says that Q-switched India laser is a long procedure. So it is my opinion, picosecond laser nowadays, since it is available in Thailand, Singapore, Malaysia, we can choose switch over to picosecond laser for this pigmented problem. And very treatment duration is very short. Second one is for vascular lesion. We used long time the Candela V-beam perfecta, pulse dye laser. Candela V-beam perfecta is a very excellent laser. Here, hemangioma, port wine stain, and many of you asked about the acne and rosacea. Pulse dye laser gives an excellent result, especially the inflammatory acne, nodular cystic acne. If we treat with isotretinoin plus the pulse dye laser for acne, inflammatory acne, and rosacea, it gives an excellent result. And another two conditions like stria distensi, it also gives a very good result. Telangiectasia, and if we can also use keloid pulse dye laser treated with first pulse dye laser followed by interlesional translunar acetonide. We did the study, and it gives also a very excellent result, in especially the resistant cases which are not responded to other modalities of treatment. Next is we have seen the rejuvenation. This is also a popular use. We have seen the Fraxel laser, non-ablative rejuvenation. Fraxel laser is very excellent. and in Thailand, they also used IPL. But I think IPL is not suitable in our dark skin. For fair skin, IPL is good for rejuvenation. We can use Fraxel laser also. And for removal of the benign skin lesion like seborrheic keratosis, skin tag, epidermal nevus, carbon dioxide laser is very good. And for acne scar, we can use Fraxel laser, non-ablative, and fractional CO2 laser for fractional CO2 or RBM laser. They gives a very good result. And another is hair removal. Already most of the experience, we use Gentiliac, that is long pulse NdF laser. That gives a very good result. Somebody may use diode also. And excimer laser, it is expensive. We used it in the 2004. It is operated by the xenon chloride gas. It is not available in our country. It is exported from, imported from USA. So it have very expensive and but excellent in treatment of vitiligo and psoriasis. So we can use this one. And I'll say another 2 points, that is the risk of hyper and hypopigmentation. It is very much common if we do not use the proper parameter and diagnose the disease correctly. And if we do not follow the thermal relaxation time of the chromophore during selection of pulse duration. So it is very important. Otherwise, we will do hyper or hypopigmentation, or we may burn the patient. So, and most of the lasers nowadays, cooling system is available with E. So it is safe if we follow the safety, laser safety, and expert hand. Without doing simple training, it is not important. As you have heard from the lecture session, that many of the lasers are available, and it depends on the types of laser, which type of laser you are using, and the brand. I think the Medlight C6 picosecond laser is for pigment laser. Picosecond is better option. Candela B-beam for pulse dye laser is very good option. For rejuvenation, you can use the Fraxel and other IPL also. And hair removal, as you have heard, these are the very safety profile of the laser. I have this much experience. Thank you very much.
Thank you, Professor Brigadier Dr. Latif, for your brilliant comments and presentation. I think and I hope that you have a good experience of handling so many different kinds of lasers while you were in your first place of posting, that is CMH. And maybe, if I'm not wrong, maybe during your period, you have procured so many good lasers in your CMH.
The laser I have mentioned, this Medlight C6, B-beam Candela, CO2 laser, long pulse NdF laser, excimer laser. This I have. This is in our center. But Fraxel and IPL I have used in Thailand during my training.
Right. So I think you have.
I think Q-switched India picosecond laser is more better. My experience.
Yeah, Dr. Latif, do you have any experience of using picosecond laser in your?
No. But I have attended many seminars. They have shown the E. And go to the literature, the pigment particle.
Yeah, but problem is that if you compare about the Q switch and picosecond laser, the price is a great issue, because every picosecond laser costs for more than 1 crore. So for particularly the economic context of Bangladesh doctors and dermatologists, I think it will be a matter.
Institution.
Yeah,
I think it is an institution, since we are treating free of cost, and we are having some budget. As an institution, we can think. Them IPGM or Dhaka Medical, they can also.
But do you know that one picosecond laser has come in Bangladesh? and that
I
has
don't
been
have.
purchased. That has been purchased from Candela, and that has been purchased by Burn unit in Dhaka Medical. But unfortunately, that laser machine has not been used yet. So it is a government purchase. Purchase has been done, but maybe nobody has even opened up the box. So we are so unfortunate that we are using lasers, but we don't have our capacity to buy a laser like picosecond laser, which is a very good option for pigment
Yes,
reduction.
yes.
Yeah,
Because I
because
have
Q
a
switch.
big
Yeah, Q switch.
experience on Q switched NDR,
Q switch,
Medlight
yeah.
C6,
Yeah,
but it takes long time.
yeah,
That is, patient is not satisfied.
it takes a big number of sessions, long time, and patients are not very much satisfied in all case. But in that particular case, yeah, maybe Dr. Swapnil Shah will give a comment.
So there is always a debate between Q switched and pico lasers, and it will be there. Like,
yeah,
I mean, anything new is introduced, there will be a lot of people pro talking about it,
yeah,
and a lot of people like, we have to find a sweet spot between these two, because pico is very good. There is no question about efficacy of pico, especially in tattoos. It straightway reduces your session by 50%.
yeah,
it's an excellent tool for ablatives, non-ablative regeneration on treatment of scar, because most of these picos has these focus lens arrays, which treat extremely good for treatment of superficial acne scars and everything. Having said that, I mean, pico is still in evolution. If you see 2 years back, what are the pico pulse width was 750 picosecond. Now it is 450 picosecond in two years.
yeah.
Maybe we are still, will still get,
even 300, even 300.
yes, and we will still get a lesser pulse width in near future. So it's too early to invest in pico, because as you said, it's an expensive machine.
Yeah, exactly. You are right, very right. So
I am telling due to academic discussion.
Yeah.
But
So
practically, many of the countries can afford this.
Definitely, sir.
We may
Definitely,
not.
it's.
Yeah.
This, since it is academic
No, you
discussion, we should disseminate our knowledge to the
yes, sir.
audience.
Actually, if you see the cost of pico, if you buy a pico, you are paying for Q switched and non-ablative like erbium glass, because that's very good for scar. So the cost become comparable if you think in this way, sir.
Yeah. Thank you, Dr. Brigadier Dr. Latif, for your nice comment. I hope that maybe in near future, any of us or any of our institute or any of our medical college hospital will come forward to purchase a giant laser or a sophisticated laser like pico. Thank you, Dr. Latif.
Our next aim is to purchase pico.
Okay, thank you.
Since we have the Medlight C6, we have both. We have both.
Okay, thank you very much. And Dr. Latif, regarding your hair removal laser, you were using gentle is long pulse, but by this time, combination of 2 lasers and also combination of 3 lasers have come already. And I have my own experience of using combination of 3 lasers, that is long pulse, alexandrite, and diode. So my experience shows that it is a very beautiful laser. If I combine these 3, so the number of sessions will be less and patients are very much comfortable. So you can also think about just purchasing this hair removal laser of 3 combinations, triple wavelength combination.
Yes,
okay, thank you.
That can be. That will be a good option.
Yeah. So now, thank you, Dr. Latif. Now I am going to invite our Secretary General of Association of Cosmetic Dermatologists of Bangladesh and Professor and Head of the Department of Dermatology, Dhaka Medical College. Today's panel of expert, Professor Dr. Rashid Mohammad Khan. He has also a very good experience about the knowledge as well as use of lasers in his practice. Professor Dr. Rashid, please.
Oh, I'd like to thank everybody. Actually, it was a learning session for me. So many users, so much of experience, especially from Dr. Swapnil. It was a learning experience. I don't have much comment. I think I have learned a lot. A few comments maybe. I think a bit of laser physics and photodynamics. we can have another session. But if you understand these are the basics of laser, you can handle laser better. Maybe to become a expert man behind the machine, efficient man behind the machine, you have to understand those things also. Just two comments about what I'm doing now for vitiligo. I think a better option is now tofacitinib, which is a targeted therapy and is safer. What I'm doing for vitiligo and also alopecia areata and alopecia totalis, tofacitinib will be a targeted safer option is very important. Another thing I have seen very good for ashy dermatosis is apremilast. It's also targeted safer option which you can use. Maybe Dr. Shopnil might have a comment on this, but it's a targeted. And if you can use other lasers, I think it could be a safer option. So with these two comments and thanking everybody, especially Dr. Shapnil and all the participants, I'm finishing. Thank you very much.
Thank you, Dr. Rashid, for your nice comment.
Dr.
Regarding your tofacitinib, so Dr. Rashid, you can combine tofacitinib as well as your UVB phototherapy or the excimer light. So you can have a very nice result for your patients if you combine your tofacitinib as well as either UVB or excimer light 308.
Yes,
Thank you,
there is very good result.
Yeah, it's a very nice information that if you combine this tofacitinib as well as the excimer light, then you can have a very good result. Thank you, Professor Dr. Rashid. Next, I am going to invite our next panelist, Dr. Jahanara Khan Jumu, Chief Consultant, Dermatology Department, Dr. Jumu Khan's Laser Medical. We know that Dr. Jumu Khan's Laser Medical, they have been doing a very nice job for last maybe 10, 15 years or even more. And we know that Laser Medical Center is one of the biggest laser center in Bangladesh, but maybe unfortunately, I may not have Dr. Jahanara Khan Jumu to say something about the lasers. Maybe she has left already, if I'm not wrong. Then I may go to invite our last panelist, Professor Dr. MD Asifuzzaman. He is one of the members of our Association of Cosmetic Dermatologists of Bangladesh, and he is a very young, energetic laser man. And maybe he has been using lasers for last couple of years, and maybe he has got enough experience of what he have been using for last couple of years. So may I request Professor Dr. MD Asifuzzaman to give his comment and remarks, please.
Thank you, sir. Assalamu alaikum. I hope everyone can listen to me. First of all, I'd like to thank our association, Professor Shiraz sir, Professor Kabir Chaudhary sir, Professor Rashid Mohammad Khan sir, and also Uniderma to organize such an excellent webinar where I was enlightened a great deal by such elaborate and detailed deliberation on lasers and its use on different dermatological aspects, not only limited to the aesthetic aspects, but also taking lasers to the dermatological diseases as well. And for that, I would like to thank Dr. Swapnil Shah, and I thank him from the core of my heart. It was really a treat to listen to you and to see all these things that you have shown. And I am still a learner. I've just started, and amongst all these distinguished delegates, I find me very, very small and still a student to learn all these things. Yes, I've been using lasers for last around 10 years or so. And there have been many lasers that we are using. Like I can talk about hair removal lasers. I started with a long pulse NDIAC laser, but then I introduced a diode laser. But in my experience to my patients, I have found diode more comfortable, and it gives a lesser number of sessions and it gives a better result. Even in cases where I've seen that long pulse NDIAC has failed to give a satisfactory result. When I shifted the patient to diode, I got a better result. That's one. Regarding keloid, I'd like to say one thing, that I've used IPL, then followed by interlesional, either triamcinolone or bleomycin. And this combination, I have got a good result about it. And regarding scar revisions, though I've been using a fractional carbon dioxide laser, but my experience, like Swapnil Shah, has been better with RF microneedling. But I have combined a PRP with RF MNT, and this have given that combination has given a better result so far. And yes, we have not gone into that picosecond laser because of the expense. We haven't been able to buy it, but we are using Q-switched NDIAG laser, both 532 and 1064, and this has been proved to be better, a very good tool in removing tattoo and also the pigment lesions. But the PIH is one factor which sometimes limit us to go for many patients about it. So this has been so far my little experience of dealing with these machines, and I would like to thank you all again for inviting me and having me as a panel expert. I wish all the best. Thank you very much.
Thank you, Professor Dr. Asifuzzaman, for your very nice comment. I think you have a very good experience of using lasers in your practice. And you are absolutely right regarding the use of diode laser in hair removal. You know, I have started my hair removal practice first with IPL. Then I have switched from IPL to long pulse NDIAG because IPL takes too much sessions and patients are not very much happy. And with long pulse NDIAG, I have done wonderful result. But even then, I have switched from long pulse to diode laser, and I found diode is even better than, in most of the cases, it is better than long pulse NDIAG. Yeah. And then now I have switched from this even to that is triple wavelength laser. And I have found that this triple wavelength laser for hair removal is very excellent because it takes laser number of sessions, and also it works very nice. And regarding your that is fractional CO2 and MNRF treatment for acne scar, I just agree with you that just mono, that is just using either CO2 fractional laser or MNRF alone, or if you combine with PRP, then it is better. So in every case, we have found that combination is better.
Yes, sir.
Always combination. Nowadays, it is said that combination is better. I think Dr. Swapnil Shah will also agree with me that in many of the cases we have seen that combined treatment is giving better result in many of the situations. So thank you, Dr. Asif, for your brilliant talk and comments.
Thank you, sir.
And Dr. Swapnil Shah, do you have any last comment or any?
No, I think I'm extremely thankful for you and the association for inviting me, and we have a great exchange of cases sharing, and I really thank you for bottom of my heart. Thank you, sir.
Thank you, Dr. Swapnil. You know, due to COVID-19 pandemic, we are unable to go to India to attend the conference. So that is why I have brought you in our Zoom webinar meeting.
Thank you.
To
Thank
find
you so much.
with us to talk about the applications of laser in our daily practice. Thank you, Dr. Swapnil. Thank you very much to be with us. Now, we have come to almost the end of today's webinar meeting. I am now going to invite one of the representation from our sponsoring company, Uniderma, Mr. Madhusudan Das, who is the DGM of Uniderma Limited, to give his vote of thanks.
Thank you, sir. Sir, can you hear me, sir?
Yeah, sure.
Yes, sir. Thank you very much, sir, for giving me the opportunity to say a few words. This is Madhusudan Das, Deputy General Manager, Uniderma. Uniderma is a concern of Unimed UniHealth Pharmaceuticals Limited. Honorable Chairperson, Moderator, Speaker, panel of experts, and all respected participants coming from different corner of, attending from different corner of Bangladesh. A very good evening. And I am feeling proud to be here with you. First of all, I would like to offer our heartiest thanks to the Association of Cosmetic Dermatologists of Bangladesh to organize this today's webinar and for considering Uniderma as the scientific partner. I am also offering my sincere thanks to the speaker, Professor Dr. Swapnil Shah from India, for his excellent presentation. I think and believe that this is a successful and wonderful webinar, and I would like to offer my heartfelt thanks to the chairperson, Professor M.U. Kabir Choudhury, moderator, Professor Sirajuddin, panel of experts, Professor Brigadier General Abdul Latif Khan, Professor Dr. Rashid Mohammad Khan, Dr. Jumu Khan, Jahanara Khan Jumu, and Professor Asifuzzaman, and all learned participants for their active participation to make the webinar successful. Uniderma is always with you. Definitely we will meet again. I hope you are good and sound health. With this few words, I would like to say goodbye. Take care of yourself. Thank you. Thank you very much.
Goodbye.
Thank you, sir. Welcome,
Thank you,
sir. Welcome,
Mr.
sir.
Madhusudan Das, DGM Uniderma, for your vote of thanks.
Welcome, sir.
I also give thanks to you and your associates and your company, because
Thank you very much.
we have so far observed that it is the UniHealth, Unimed, and Uniderma who is always with us to arrange
Thank you very
such
much.
a webinar or even sometimes
Thank you,
scientific meetings. Thank you very much.
Welcome,
Thank
sir.
you to your company.
Welcome.
And thank you also Mr. Anis for his very nice cooperation with us. So
Yes, sir,
now we are going to the end of today's session. I'm sure that all of us have learned so many things from our today's learned speaker, Dr. Swapnil Shah. And it is a very long session. Maybe all of you have already become tired of hearing so many things about lasers. And I agree with Dr. Rashid Mohammad Khan that we should arrange one more session about the basics of lasers. Because if I cannot understand the basic of laser, then I cannot do any laser session in my patients. So we should know the basics of laser first, then we should go to apply the lasers in our practice. Thank you, everybody. Thank you, all the members of Association of Cosmetic Dermatologists of Bangladesh. Thank you, all the dermatologists who have attended this webinar meeting. Thank you, Uniderma. Thank you,
Welcome,
everybody.
sir.
Now I am going to invite our chairperson of today's session, our president, Professor Dr. M.U. Kabir Choudhury, as president of Association of Cosmetic Dermatologists of Bangladesh. He has come to join us from Canada, and he always very much energetic to attend and to arrange and to do everything for our association and also for our community. So Professor M.U. Kabir Choudhury, for your chairperson's speech and also for concluding remarks, please.
Thank you, Professor Siraj, for arranging such a wonderful conference by the name of God, and who is the source of knowledge of wisdom. So I'm very much thankful and grateful to Professor Dr. Swapnil Shah for wonderful, very, very elaborate and nice presentation on laser practical experience and his chamber and his practice. And he's one of the pioneer of laser surgery in subcontinent in Southeast Asia. We are very, very fortunate to get him in our discussion. So today we are going to discuss and fundamentals of laser. Dr. Siraj was saying about fundamentals. So laser started only 1817. Albert Einstein first thought about lasers. And later, after only 1 year, 1818, Planck got the Nobel Prize in laser discovery. But in 1960, after almost 80 years, my man who discovered he started this laser for medical use. But in dermatology, the Leon Goldman is the person who is the father of laser, and he started laser in dermatology. And you will know that laser application in medicine, dermatology is the pioneer, was pioneer, is pioneer, future will be dermatology the pioneer. Though a center like a plastic surgeon will buy pico laser, but the laser must be used by dermatologists because it always is a laser and with dermatologist. So thank you, Dr. Shapnil, for wonderful presentation and everything you have covered. I have nothing to tell about laser. And when laser was first introduced by 1963, Leon Goldman, but in 1984, FDA given the approval of medical laser to use. And 1985, I joined in St. Thomas Hospital. I had my training. And then only whole United Kingdom, there was one laser machine in St. Thomas and St. John's Skin Unit. And that was a Ruby laser. I have started in almost 35 years back. And the laser started from that place. And the laser, if somebody wants to know the basic, we must know the physics. Because one renowned physicist in London who encouraged me to learn laser. So physics is the fundamental, then chemistry, and also physiology. We must know to learn the laser. So laser first was measure. It was called measure because of the microwave application. Then it's in laser. Laser means oscillation of light. Later now name is the laser. So after FDA approval, laser became so quickly. It is the fastest growing subspecialty in medical division than any other in the world. So we are using laser every places. I had experience of almost using all the lasers like candela, B-beam, or your B-beam is wonderful. It is a dye laser, and for so many things already discussed by all the persons. Long pulse energy also gentle yak was very good, and so many lasers. Pico laser is another laser because we have started in second, millisecond, then nanosecond. Now it's called picosecond. So pico wave is creating big wave in the world. And it is so quickly, it erases the relation. It's wonderful. I have attended so many conferences, workshops with pico laser, and we'll be very happy to have a pico laser in our country for show the result very, very early. And laser, everybody use the laser, very important. First of all, we know about the side effect. It may cause erythema, it may cause a burn, it may cause a blister, it may cause an ulcer. So we, in mind, we must select the patient, which laser to be used. So you must have a good training under a good specialist to start with the laser, all my young generations. And here also, I thank you to Asif Jaman, a very young professor and going enthusiastic in the laser. I hope they will lead the laser further, though we have started laser. I have started first laser center in Dhaka. It was in 1988 with Remit, is Russian laser. Then we have started this laser with medical laser Juma Khan, and then we started the second laser center in Bangladesh. Though this is the largest laser, then Shamim also doing well. All the laser centers now throughout the country. Siraj is very much knowledgeable about the machine, about the disease, about the application, and about the webinar or seminar. Anytime I call Siraj, where are you? Well, I am in California. I am in New York, somewhere. Another very good news already, Dr. Shapnil told you, the Patel Kumar Patel, Indian in 1963, who discovered carbon dioxide laser. And it is a pride for our Indian subcontinent, we people. Indian are always advanced. So I thank everybody to come here, and we pay our homage to our front fighter of COVID-19, all the doctors of the world, including Bangladesh and all the places. And we should be always careful, stay at home, be careful, but any chance to fight the COVID-19. So everybody should be safe, and all my prayer for everybody participant, and for your participation, my thankful and grateful for this arrangement. And Siraj is always doing in my favor this arrangement, and he's very, very expert. He knows the world, he knows the people of the world, and he invites, and everybody comes on invitation because he's a very popular person in the world. He's a global popular dermatologist in the world. So I pay my thanks to him and Dr. Rashid Mahmoud Khan, all the participants, and for the nice comment. All the experts are here. So all about this. And anybody want to start a laser center, a new people must you do the study. After study of the laser center, then you do the laser center, then do your training and go with this. Thank you very much. And it was a wonderful session. I learned so many things. Though I started laser almost 35 years back, long time, but I learned so many things from Dr. Shapnil, and my gratitude to Dr. Shapnil again and again. And thank you all the participants. And Uniderma is always making this nice arrangement with their finance and their partnership. I thank Uniderma for their participation in every program we see. Thank you very much. Here I conclude. And we should make this sort of program for our learning, for ourselves, for our patient, for our country, for our investment. And we hope future will do this sort of webinar again and again, because everybody is free now, can think those. I am not that much free. I started my work 2 a.m. in the morning, and now it is 12:30 afternoon. I was working with my patient online. So thank you very much again for this arrangement. And this is the conclusion. You can just conclude the session. Professor Siraj can say the conclusion, and we can end up here. And thank you very much for such a long time. Dr. Swapnil was with us. Again, thank you.
Thank you. Thank you, Professor Dr. M.U. Kabir Choudhury, for your very brilliant and very nice information about the history of lasers, because we did not cover that part. I know that it is Professor M.U. Kabir Choudhury who will take part to say something about the history, because every time I know that about history of any disease, anything, you know, very nice information about the history.
Thank you.
Thank you, everybody. And with the permission of our chairperson, Professor M.U. Kabir Choudhury, I may go to conclude this session officially. Thank you very much.
Thank you, sir.
Dr. Rashid, officially closed. এখন কথা বলেন। আনিস সাহেব,
স্যার,
সবাইকে আনমিউট করে দেন।
আচ্ছা, this is the time for unmute.
Dr. Khalil was there, huh? Khalil.
Khalil bhai, salam alaikum.
Salam alaikum.
বদরুদ দোহা স্যারকেও দেখতে পাচ্ছি।
প্রফেসর দোহা,
স্যার আনমিউট করে কথা বলেন।
কেউ কিছু বলবেন নাকি? এখন সবাই বলতে পারেন।
স্যার আপনার সাউন্ড পাচ্ছি না, দোহা স্যার।
এখন আমাদের সাথে প্রায় 31, এখন আমাদের সাথে 31 জন যুক্ত আছেন। ইনক্লুডিং মি 31 জন যুক্ত আছেন। এখন সবাই কথা বলতে পারেন ফ্রিলি। ডক্টর দোহা,